Good afternoon and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speaker with commercial interests have been mitigated. If you have a question for the presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is now my pleasure to introduce our guest speaker today, Dr. Pearl Kode. Dr. Kode was born in Cameroon and brings a diverse academic and clinical background to her work in medicine. She holds 2 bachelor's degrees, one in biochemistry and another in nursing, and began her healthcare career as a registered nurse. She later pursued her medical degree at Ross University School of Medicine. Currently, she is a PGY3 internal medicine resident and plans to practice as a primary care provider following residency. Outside of her professional life, she is a devoted wife and mother of her 2-year-old daughter. Please join me in welcoming Dr. Kode.
My name is Pearl Kode. I'm a PGY3 internal medicine resident here in the hospital. Today we're going to be talking about osteoporosis, just to go over some little pearls that internal medicine physicians can start doing for our patients before even sending them to a specialist. I have no disclosures. However, I want to say that recently I've had recurrent upper respiratory infections, so I tend to lose my voice, so please bear with me. These are the objectives for today. Number 1 is to state the current screening guidelines and diagnostic criteria for osteoporosis. I want us to be able to identify major risk factors and utilize fracture risk assessment tools. Also to be able to identify the importance of early initiation of treatment, to apply evidence-based pharmacologic treatment strategies, to understand bisphosphonate duration and the drug holiday concepts, and also to state the indications for anabolic therapy in very high-risk patients. So let's start from the beginning. What is osteoporosis? This is a definition by WHO. Osteoporosis is a progressive systemic skeletal disease which is characterized by low bone mass and microarchitectural deterioration of bone tissue, leading to increased bone fragility and susceptibility to fractures. So if we look at the first picture there, that's a normal bone. You can see how thick it is. So it has good bone mass, and you can tell that it's kind of a square shape, so the architecture is still intact. The middle picture is for osteopenia, where we do have low bone mass, but you can still kind of tell that it is a square shape to some extent. And then lastly, we do have the picture. You can tell that we do not have good bone mass, and also you can't quite tell if this was a square or if this was a triangle or whatever. So this is osteoporosis, where we do have both loss of bone mineral density as well as the architecture of the bone. Let's go over some causes for osteoporosis. We do have primary and secondary causes. Primary causes really just means that the patient does not have any underlying bone disease or medical condition that puts them at risk for osteoporosis. So we're just going to be looking at some risk factors. Type 1 osteoporosis here means these are postmenopausal females who have estrogen deficiency, and the deficiency in estrogen leads to increased osteoclast differentiation and activation. That's going to lead to more bone resorption than bone formation, and hence weak bones. Type 2 is the senile type, which is age-related progressive decline in osteoblast supply. So then we have decreased bone formation while osteoclast activity is still going on to resorb the bone. So eventually we have more resorption than formation. Another important risk factor is sedentary lifestyle. Our bones do need that mechanical load to stay where they're supposed to be at. So if we're not active, then we start to lose our bone density, again leading to more bone resorption. Smoking and alcohol intake, of course, are risk factors for pretty much everything at this point. Secondary causes of osteoporosis, these are either bone-related diseases or just medical conditions that put patients at risk for osteoporosis. Again, just like with the primary one, patients can have estrogen deficiency due to some underlying medical condition like hypogonadotropic hypogonadism or hypergonadotropic hypogonadism, meaning that our ovaries are not producing estrogen like they're supposed to. Hypothyroidism is also an underlying condition that predisposes patients to osteoporosis because thyroid hormone causes more bone resorption. Hyperparathyroidism, for obvious reasons, it does mainly cause bone resorption over bone formation. And of course, if you do have malabsorption, if you're not having the nutrients that you need to form bone, your bones are not going to be healthy, and then they're going to be brittle and at risk for osteoporosis. So patients with Crohn's and gastric bypass or just eating disorders with vitamin D and calcium deficiency are at risk for osteoporosis. These are some more secondary causes. We already talked about vitamin D and calcium deficiency. Medications, which what we put patients on pretty much. Glucocorticoids, we have a lot of patients on that. Chronic use of that can predispose a patient to osteoporosis. Our PPIs that we use for acid reflux, they do reduce the acid content in the stomach. That also reduces vitamin D absorption, causes vitamin D deficiency, calcium deficiency, and all that, eventually leading to weaker bones and osteoporosis. Chronic use of heparin. Patients typically will be on heparin for over 6 months to have these put them at risk for osteoporosis. And again, levothyroxine, which is a thyroid hormone, and medroxyprogesterone. Typically, if you're getting progesterone, it can inhibit your pituitary gland from producing gonadotropin secreting hormone. That's going to lead to decreased estrogen production and decreased formation of bone as well. Adrenal insufficiency is another medical condition that predisposes patients to osteoporosis, Cushing's disease as well. And then there's this rising idea that GLP-1 agonists, which we now use for weight loss, and diabetes as well, can predispose patients to osteoporosis. I think there's still some research going on about this. The idea behind this is if you lose a lot of weight, again, you take away that mechanical strain on your bones, you have weaker bones, and then you predispose yourself to osteoporosis. So what's the pathophysiology of osteoporosis? It's really an imbalance between bone resorption and bone formation, leading to a net bone loss. So in our body, messed it up. Typically, we have both processes going on in our bones, but for some reason or the other, based on the risk factors that we already talked about, some patients may have more bone resorption than bone formation. Then they're going to have a net loss of bone, hence putting them at risk for osteoporosis. So that's the main pathophysiology behind osteoporosis. There are two molecular pathways that lead to osteoporosis. One, which a lot of us are very familiar with, I remember learning this in medical school, is the rank ligand system. This system typically regulates the osteoclast formation, activation, and activity. Rank is a ligand that's found on osteoclast and stromal cells. Once released, they bind to osteoclast and tell them to go ahead and do bone resorption. And then rank is a receptor for the rank ligand on the osteoclast precursor cells and mature cells. Again, once a rank ligand binds to rank, it tells the osteoclast to initiate bone resorption. Can't pronounce that word, but osteoprotegerin is a decoy receptor that binds rank ligand. And once that happens, the osteoclasts don't have enough signal to go ahead and do bone resorption. So binding of this molecule to the rank ligand reduces bone resorption and promotes bone formation. We're going to see a diagram that explains that further. So that's the diagram. So we see the rank ligand that's on the stroma cells and osteoblast cells, and then they also carry the osteoprotogerine molecule. So if the rank ligand successfully binds to osteoclast precursors, it tells them to go ahead and begin bone resorption. So they regulate each other's activity. We're going to see another molecule that the osteoclasts use to regulate osteoblast activity. But if the osteoprotogerine binds on this ligand, then the osteoclasts do not have any signal to go ahead and do bone resorption. So then we're going to have more bone formation than resorption. Some of the factors that we already talked about, parathyroid hormone, this increases the expression of rank ligand, hence it's going to increase osteoclast activity and bone resorption. We have glucocorticoids, chronic use of that, and then estradiol also increases the rank ligand. And then other factors as well, similar factors which regulate the OPG production and bone remodeling. This is the second key molecular pathway, which is a WNT/sclerostin pathway. This one regulates the osteoblast. So the previous one regulates osteoclast. This one regulates the osteoblast to promote bone formation. And then sclerotin is a molecule that is produced by osteocytes to regulate the osteoblast. So if the osteocytes secrete this molecule and it binds to its receptor, it inhibits bone formation, hence bone resorption is going to be higher than bone formation. We're going to talk more about that because that's the target for one of the newer medications that are used for osteoporosis management, which is called romosozumab. So what is the scope of this osteoporosis problem? We have both clinical and just the burden of disease. So the clinical significance is that osteoporotic fractures are associated with substantial morbidity, mortality, and reduced quality of life. Hip fractures carry a particularly higher mortality risk. Of note, it's very important to take note that 70% of these osteoporotic fractures occur in patients without osteoporosis by mineral bone density criteria. And this is a big area where we have a lot of gap. When we do the DEXA scan, we're looking at the bone mineral density, and if the patient is not in osteoporotic range, then we're like, oh, we're just going to monitor it. However, knowing that most of the fractures even occur before patients get to the osteoporosis range, that is an area of improvement that we need to work on and try to start these patients on treatment. The burden of the disease worldwide, 1 in 3 women and 1 in 5 men over the age of 50 experience osteoporotic fractures. It's estimated that about 54 million Americans have osteoporosis or low bone density. And then it was estimated that by 2025, the economic impact was going to be about $25.3 billion annually. So we can imagine what it is now in 2026. Who do we screen for osteoporosis? We usually go by the USPFTS, which recommends that women greater than or equal to 65 years, we can start screening them. For postmenopausal women who are less than 65 with one or more risk factors for osteoporosis, we can also screen those based on the risk factors. And then they don't really have any recommendations for or against screening men. So we just have to use that clinical decision. If a patient has a lot of risk factors, then maybe we should consider screening the man for osteoporosis. And they do not specify the screening interval, but we typically do it every 2 years, sometimes 1 year if we're treating the patients, but most insurance companies only cover 2 years, whether or not they are being treated. The American College of OBGYN recommends that we screen women over 65, younger postmenopausal women with FRAX score over 8.4%, And then the Bone Health and Osteoporosis Foundation recommends that we screen women 50 to 64, men 50 to 69, and then all women over 65 and all men over 70. But again, we typically go by USPFT as recommendations. How do we diagnose osteoporosis? We typically use our DEXA scan reports. So if we get a T-score that's greater than -1, that's normal. Between 1 and -2.5, that's osteopenia. And then anything less than or equal to -2.5, that's considered osteoporosis. But just like we discussed earlier, most of the fractures occur before the patients get into the osteoporosis range. So we do need a clinical criteria to diagnose these patients who do not meet this criteria but are at higher risk for osteoporosis and fractures. So that's where the clinical diagnosis comes in. We diagnose osteoporosis in patients who have had any fragility fracture, which is a fracture from low impact trauma. So if you fall from just a standing position, you should not be breaking your bones. So that counts as osteoporosis. And then if they do have osteopenia and a high fracture risk, that also counts as osteoporosis, and they should be treated. So who do we treat? Again, based on bone mineral density on our DEXA scans, or postmenopausal women who have had a history of any fragility fracture. And then for our osteopenic patients, we have to use our FRAC score to risk stratify them and see if they meet criteria for treatment. And the FRAC score just gives us a 10-year probability of a hip fracture or major osteoporotic fracture. I wish I could show you guys the FRACs, but it won't let me share with you guys, but it just goes over like the risk factors for the patient. You have the patient's country of origin, continent, their age, gender, weight, height, and then you have some other risk factors that we talked about previously, and then it generates a score for patients. So now that we have our patients who meet criteria for treatment, what do we do before treating? We want to make sure that we have our ingredients that are needed for bone formation, which are vitamin D and calcium. So our calcium needs to be within normal limits, and then vitamin D should be at least 20. It's still insufficient, but we can put them on vitamin D. In fact, all our patients who are at risk need to be on some form of calcium or vitamin D supplements. For postmenopausal women, they need to be on at least 1,200 milligrams of calcium and 800 international units of vitamin D. And then for our premenopausal women or men with osteoporosis, they need to be on at least 1,000 milligrams of calcium or 60 international units of vitamin D. It's also important to assess the renal function because, one, you can consider referring them to a specialist like a nephrologist who can manage their kidney disease-related bone disease, or patients who have GFR less than 35 cannot be on bisphosphonates. So it's very important to know what their baseline renal function is before you can start treatment. Let's go back to the evolution of management of osteoporosis. The link between menopause and osteoporosis was first identified in the 1960s. At that time, we didn't have any diagnostic tools, no diagnostic criteria, we didn't have any screening protocols. So the management at that time was really just replacing estrogen, calcium, and vitamin D. And then in the 1990s, that's when we got the DEXA scan for screening and then the WHO criteria for diagnosing osteoporosis in 1994. And then in the mid to late 90s and early 2000s, that's when we had the first pharmacotherapy agents for management of osteoporosis, and these are the bisphosphonates. Alendronate in 1995, risedronate in 1998, and zoledronate in 2007. And then by 2008, we had the FRAC score, which we talked about earlier. And then by the early 2000s, that's when teriparatide was discovered as a potential agent that could be used for management. Most recently, from 2019, we've had a paradigm shift where initially, if you diagnose a patient during this period, you always needed to start on a bisphosphonate, and then you can up-titrate as needed. But as of 2019, we're starting to learn that patients at very high risk could be started on anabolic therapy right off without even going to bisphosphonate. So that's an important key point to take note of. What are the treatment options for osteoporosis? Like we talked about earlier, bisphosphonates are the first-line treatment for osteoporosis, and the mechanism of action is listed there. Pretty much, they inhibit osteoclast activity and reduce bone resorption. They are first line because they are relatively cheaper than the other options. They have good efficacy, and compared to the other options, they can be used long term if their renal function tolerates. We have both oral and IV options. Mainly we use alendronate, which is Fosamax. It can be a daily or weekly oral tablet. And then we can also use IV zoledronic acid, which is usually an IV option, giving annually. Very important on bisphosphonates. If you're starting a patient on those, you want to educate them on how to take bisphosphonates. They need to take it first thing in the morning on an empty stomach with water only, because taking it with food or juice or milk or whatever is going to reduce the absorption of the drug. Hence, it's not going to be as active as we expected it to be. They also want to sit up for about 30 to 60 minutes before taking any meds or food, because there's a risk for esophagitis if taking bisphosphonates orally. Of course, we want to avoid in patients who have any kind of esophageal disease, like esophageal disorders, if they've had any bariatric surgery with anastomosis in the upper GI tract, again, just to reduce the risk of esophagitis. Avoid in GFR less than 30 to 35. Common side effects that are seen are like nausea, heartburn, abdominal pain, flu-like illness, mainly with the IV zoledronic acid. And then severe side effects, esophagitis, like we talked about earlier, osteonecrosis of the jaw, and atypical femoral fracture. And why is that? If we're trying to reduce osteoclast activity, the bone should be stronger, right? But remember we mentioned earlier that these two pathways occur simultaneously. We have to build and break down bone so we have healthy bone. So if we are preventing the breakdown of bone, we're going to have a lot of bone there, which may not necessarily be healthy. Eventually, it's going to become necrotic and put them at increased risk for fractures. Duration of treatment for oral agents, we want to limit them to 5 years if possible. You can always get your DEXA scan, and if they are stable, then you can take them off of that. If they are improved, then you could extend it to about 10 years for the oral agents and 6 years for the IV agents. Something that is also very important for bisphosphonates is the drug holidays. This is going to limit the side effects, the severe side effects that we talked about, these ones here. However, we don't really have a clear-cut understanding of how long these holidays are, but it's typically about 2 to 3 years. The second class of medications that we use are called anti-resorptive agents. The first on the list is denosumab, which is a Prolia. That's what it looks like there. Mechanism of action is it's a monoclonal antibody to the rank ligand that we talked about. It was FDA approved in 2010, and it's a sub-Q injection every 6 weeks. So this one could potentially improve adherence to treatment. You can use this in patients who cannot take bisphosphonates for whatever reason, especially the renal patients. And then common side effects are going to be injection site irritation. You can also have hypocalcemia. And then most severely, you can also have the osteonecrosis of the jaw and atypical femoral fracture. Pros for denosumab, it has a higher efficacy than bisphosphonates. The ease of administration is every 6 months. You can use it if they have renal impairment, and there is no limit to the duration of treatment. However, it is very expensive. A dose of Prolia is about $2,000 compared to $100 for a year's worth of alendronate. and it's contraindicated in pregnancy because it's a teratogen. And then when you're starting a patient on denosumab, it's an indefinite treatment unless something comes up and you need to stop it. So you always want to discuss this with the patient and say, "This, we're not going to go back on this. Once we start this, we're not stopping it." So the patient knows that it's a lifetime commitment on Prolia. But if for some reason you have to stop it, then you have to put them on some other therapy because they do have very rapid bone loss after you stop denosumab. So shifting to the anabolic therapies, the main action for these agents is to form bone. We use them as a step-up therapy for anti-resorptive therapies, or we can just go ahead and start them for patients who are very high risk for fracture. So if they have a T-score of less than or equal to -3, should be say -3, even in the absence of fracture, or if they have osteoporosis with fragility fractures, you can just go ahead and start them without paying too much attention to bisphosphonate. First on the list is teriparatide, which is for TEO. It's a synthetic parathyroid hormone, so it does stimulate the blast more than the class, so more bone formation than bone resorption. It was approved by the FDA in 2002, and it's a sub-Q injection that patients can do this at home every day. Common side effects: nausea, dizziness, and hypercalcemia. However, one main limitation with teriparatide is you can only use it for 2 years because studies in rats showed that rats had increased risk of osteosarcoma after 2 years. So we can't use it after 2 years. You have to stop it and switch to something else. Similarly, we have, I can't say that word, abaloparatide, goes by Timlos, very similar to teriparatide. It's a parathyroid hormone-related peptide analog, which again stimulates blast bone formation. It was approved in 2017. It's also a daily sub-Q injection. Similar to teriparatide, you cannot use it for more than 2 years for the same reason, risk of osteosarcoma in rats. Contraindicated in bone cancer, hypercalcemia, and pregnancy. Most recently, I think most of us could be familiar with the first two that we talked about, but this was most recently approved in 2019 by the FDA. It is a monoclonal antibody to sclerostin, so it inhibits that. And if you remember, sclerostin inhibited bone formation. So if we inhibit that, it's going to lead to bone formation. The interesting thing about this agent is that it does both increase bone formation and decreases bone resorption, so you have more bone. It's a monthly sub-Q injection. You can only use it for 12 months because we're going to see some research later. Beyond 12 months, patients did not have a lot of benefit from these medications, and they were also at risk for cardiovascular events like strokes and MI and other severe complications. So of course, it's contraindicated in stroke patients or patients who've had an MI within the past year. So first is the FRAME trial, which was done, it was a phase 3 trial, randomized, double-blind, placebo-controlled, published in New England Journal of Medicine in 2016. They enrolled over 7,000 postmenopausal women with osteoporosis, and they were comparing romosozumab versus placebo for 12 months, followed by another year of denosumab. The romosozumab group showed reduced fracture risk compared to placebo at 12 months. It also showed substantial bone mineral density increase compared to placebo. Looking at the top, that shows the incidence of new vertebral fracture. This is a placebo group, and this is a romosozumab group. We see that they have a lower incidence of new vertebral fractures in the romosozumab group compared to the placebo group. And this was at 12 months. This is at 24 months, and we still see similar benefits, and both of them are statistically significant. At the bottom, we are looking at clinical fractures, which they defined it as any fracture that a patient presented to the provider with symptoms, so hip pain and then found to have a fracture. That's a clinical fracture. We also see that the romosozumab group did better compared to the placebo group, and it was statistically significant at the 12-month mark, but not at the 24-month mark. So that's one of the reasons why we only use it for 1 year. Similarly, on this side as well. Can't read. These ones show us the change in bone mineral density in the lumbar spine. This is the, can't see, romosozumab group, and then denosumab, and then this is a placebo group. So we see that they had an increase in bone mineral density in the romosozumab group. So overall, it looks like we had benefits with romosozumab group, at least for the first 12 months. At the bottom, we see these molecules. These are markers of bone resorption. So increase of these two agents or markers mean that we have more bone resorption. So we see that romosozumab also did decrease bone resorption, not so much change from the baseline in the placebo group on both of them. And then we go to the ART trial. This was another phase 3 trial, double-blinded, randomized, controlled. Was published again in New England Journal of Medicine in 2017, where over 4,000 postmenopausal females were enrolled in a 1-to-1 ratio. They received monthly romosozumab versus weekly alendronate, and then followed by alendronate alone for 12 months. Again, in the romosozumab group, followed by alendronate, they had significantly reduced fracture risk compared to alendronate alone group. So similarly, this is a romosozumab group. We had decreased incidence in new vertebral fractures, same at 24 months as well, and they're both statistically significant. And then the first clinical fracture, time to event analysis, romosozumab again did better than alendronate. And then looking at the change in bone mineral density in the lumbar spine, total hip, or just two, we also see that romosozumab did better compared to alendronate. But that makes sense because alendronate is an anti-resorptive agent, so we don't expect it to do much change compared to romosozumab. Of course, when we come to the signals for bone resorption, we see that alendronate did better because it's an anti-resorptive agent. This is another study that was published in Orthopedic Surgery Journal. It compared romosozumab versus teriparatide in the treatment of postmenopausal osteoporosis. It was a meta-analysis, so it included 4 randomized controlled trials, again comparing romosozumab versus teriparatide for treatment. Over 1,000 patients were involved. Overall, they also saw that bone mineral density significantly improved in the romosozumab arm compared to teriparatide, and there was no significant difference in the adverse events. At the top there, we see that's a 6-month. We see that it favored romosozumab. And this is a forest plot that's representing lumbar spine bone mineral density at 12 and 6 months. So this is a 12-month, so that the romosozumab group did better. And this is the 12-month, again, romosozumab group did better, and overall, it did better than teriparatide. And then this is a forest plot that's showing us the hip at 6 and 12 months. Again, the romosozumab group did better compared to teriparatide on all the trials that were used in the meta-analysis. This is another forest plot for femoral neck. Again, same results. with romosozumab compared to teriparatide. So it's looking very promising. And then this one showed the incidence of adverse events at 12 months. We see that most of them are not statistically significant. We had two that showed that teriparatide had more adverse events, but overall there was no difference. So newer therapies, I think these two were approved in 2025. Sorry, Jubbonti is, these are romosozumab biosimilar. So again, they work with the rank system. Jubbonti is interchangeable, meaning that if you prescribe Prolia and the insurance doesn't want to pay for that, then they will ask the pharmacy to dispense Jubbonti. They don't have to ask the provider, they can just go ahead and do that. As opposed to Stoboclo, which is non-interchangeable, the pharmacist has to contact you to switch it to that. So this is what both of them look like. But similarly to denosumab, they work similarly, similar side effects, and these are cheaper. I think Jubbonti is like $500, and then denosumab was $2,000. What's the role of estrogen in management of osteoporosis? In the early 90s and 2000s, the Women's Health Initiative did a few trials that show that estrogen replacement in menopausal women prevents bone loss, but it came at a cost, of course. You can have CAD, thromboembolic events with both estrogen or estrogen and progesterone agents. So something to keep in mind when we're using this. They are not the first line for osteoporosis management. Of course, we have better options. Why use estrogen when you can use romosozumab for your patient? Patients who are already on estrogen or menopausal hormonal therapy with estradiol may not necessarily need another therapy. So if they're in the osteopenic range, they may not need you to start on the bisphosphonates, but you have to closely monitor them to make sure that they don't progress. If that happens, then you have to switch to another agent. Raloxifene, we don't really use this much, but it's another option, but it only reduces vertebral risk fracture. So that's a limitation to that. Inpatient management of osteoporosis. How many times have we seen patients with hip fractures? I think the laws changed now. We don't see them a lot, but previously we used to see them on our MTS teams, and we just discharge them home without thinking about it, unfortunately. But that does count as fragility fracture if they fell from a standing position and had a hip fracture. So that's where we come in as internal medicine providers. There was this article that I read that was published in 2022 in the, I think it was the Hospitalist Journal or something, and they said that co-management between hospitalists and the orthopedic surgeons, when it came to vertebral compression fractures, patients had better outcome or earlier initiation of osteoporosis treatment. So we can kind of extrapolate and say that if it worked for vertebral fractures, then we can also play that same role and initiate treatment for our patients, whether it be hip fracture or whatever fracture that they have. Of course, you want to correct your calcium and vitamin D deficiencies. Zoledronic acid can actually be started in patients on post-op day 2 or later because one, we can easily monitor the patients, make sure they don't have any side effects, and then it's a 1-year infusion, so they have time. Even if they don't follow up, at least they had that in their system. And in fact, there is a study that was released in 2025 which showed that patients, I think they were less than 60, still had benefits from zoledronic acid even up to 10 years after a 5 milligram infusion. But again, those were younger patients, less than 60. So, but maybe we could consider using that. Typically, we use the 5 milligrams, but I think studies have shown that with CKD patients, you could use 3 milligram or lower dose, and patients did not have any severe side effects with that. Alternatively, you can initiate bisphosphonates or denosumab at discharge. There's also something called fracture liaison service, which I don't know that we have it here, but it's something that orthopedic teams use is another team of providers who work with the orthopedic surgeons and ensure that patients who are needed with these fragility fractures meet criteria for osteoporosis, ensure that they get treatment even after they leave the hospital. So this is also something that we can implement. When do we initiate bisphosphonates? Like I said, we can do zoledronic acid 2 days post-op or later. I found this article where they were looking at the ideal timing to initiate bisphosphonates. The aim of this was to analyze the benefits and adverse effects of early administration of bisphosphonates and give recommendations regarding when they should be utilized. It was a meta-analysis that included 10 randomized controlled trials and almost 3,000 patients. 4 of the trials used alendronate, 3 used zoledronic acid, and 2 used residronic acid, and 1 used that. They found that early administration of bisphosphonates delayed they were comparing early administration to placebo versus delayed administration of bisphosphonates or no therapy at all. There was no significant difference in the radiographic fracture healing time. So I think the concern here was if we're starting bisphosphonates, then the bone is not going to heal after the fracture and repair, which is what we want. So the aim of this meta-analysis was to show that, yes, there's that concern, but overall, we didn't see that in the clinical trials that were considered. So there was no difference in the rate of delay or non-union fracture healing. And then the bone mineral densities in the hips did significantly improve after 12 years of treatment of bisphosphonates. So do not shy away from starting bisphosphonate treatments. Even if they've had fractures, they should still be okay. How do we monitor patients when we're treating them? It's recommended to do DEXA scan every 1 to 2 years. However, most insurance companies will not pay for it, so we just do it every 2 years. What are we looking for when we do these follow-up scans? We want the bone mineral density to exceed the least significant change, which is usually reported on the DEXA scan, or if they have an improvement in their bone mineral density by 5% or more. So that's what we're looking at. That's the goal. If the patient's bone mineral density is stable or improved, you can continue the same treatment and then repeat the DEXA scan after 2 to 5 years. I'm not sure how well you guys can see this, but this is a nice algorithm that I found on UpToDate. You can look that up when you have some time. But it just goes over, once you start a patient on the bisphosphonate, what are the steps that you have to look for? If there is a decline in the bone mineral density, or if the patient had a new fragility fracture, then you go down this path. You want to make sure that they're taking the bisphosphonates. If they have any GI absorption issues, you address those. But if they're stable, then you can just do a DEXA scan after 2 years and go from there. So nice table on UpToDate. Some ongoing research. We have gene therapy to modulate bone metabolism that's ongoing. And then we have research on sequencing and combining therapy. So one interesting one is sequencing really just means what you start with and then what you continue with. And it's showing that romosozumab can be started first, and then you can either switch to denosumab or bisphosphonates after that. So this is some ongoing research that we can follow up on. So key take-home points. Most fractures occur in the osteopenia range of bone mineral density, so make sure that you're doing your FRAC score and treating the patients that need to be treated. Early identification of patients, that's what we talked about. And then bisphosphonates are first line. However, you can always start them on anti-resorptive agents if they're at very high risk. Make sure that you monitor treatment. If the patient is not improving on the bisphosphonates, you can always escalate treatment. Be mindful of the treatment duration. So if they say do not do teriparatide for 2 years, make sure that you stop it, else you're putting the patient at risk for developing osteosarcoma. Again, make sure that vitamin D and calcium are well supplemented and address their underlying conditions that are predisposing them to osteoporosis. Questions? Is 65, so we're just going to review, make sure that you are listening. A 65-year-old female comes to the clinic to discuss DEXA scan results. She has been healthy all her life, has no medical conditions, and takes no medications. She experienced menopause at 52. She lives alone, is independent, and has no children. Vitals are stable. Physical exam is unremarkable. BMI is 22. DEXA scan results are shown at the femoral neck and lumbar spine, respectively. CBC, CMP, and phosphate are within normal limits. Which of the following additional investigations should we perform for this patient?
Okay, let me phone a friend. We're going to go with B as in boy.
B as in boy, that's correct. We want to make sure that calcium and vitamin D are appropriately corrected before we initiate treatment. And this patient does need treatment. Great, you were listening. Second question, 75-year-old female comes to the office due to compression fracture at T10 sustained after sleeping in the bathtub. Past medical history, hypertension, diabetes, hyperlipidemia, CKD4. She is compliant with all her medications, including calcium and vitamin D supplements. CBCs are remarkable. CMP, she has a creatinine of 2.4, GFR 21%. DEXA shows -2 and -1.8 in the lumbar and femoral neck, respectively. Which of the following is the best next step to reduce this patient's risk for fracture?
C as in cat.
C it is. Good job. All right, lastly, a 67-year-old female comes to the clinic to discuss DEXA scan results. She has a history of rheumatoid arthritis, polymyalgia rheumatica, and has been compliant with her medications. She experienced menopause at 55. She's independent with no history of falls or fragility fractures. Vitals are normal. Physical exam, significant for minimal tenderness at the MCP joints. DEXA scan is listed. CBC, CMP, vitamin D, phosphorus are within normal limits. Which of the following is the best next step in the management of this patient? Yes, A is the answer.
Oh, A is the answer.
She has osteopenia, but she also has risk factors. Rheumatoid arthritis is another risk factor for osteoporosis. And PMR, she's probably on steroids. So 2 risk factors, osteopenia, you want to calculate the FRAX score and see if they need to be treated. These are my references. Thanks to Dr. Suloff and Dr. Gross. Questions?
Thank you, Dr. Kode. I'll remind you, if you're viewing online and have a question, please put it into the Q&A section and we'll ask that for you. And we do have a couple of questions in the audience.
Yeah, thank you for the presentation. It was a really great review for management of osteoporosis and osteopenia. I think one really great point that you brought up was initiating treatment for osteoporosis before leaving the hospital for patients with fragility fractures. I don't know if this is like just because it made sense in terms of the mechanism of action, or if older studies just showed that there was a delayed healing with starting bisphosphonates. But it's great that we have evidence that says, no, just go ahead and start the bisphosphonates before they leave the hospital, and that it has better outcomes. But there's usually a lot of resistance when you try to bring those up. I don't know, again, is it pathophysiology? People are like, oh, it just makes sense that it is a bad idea, or if there was older evidence. But that's great that we have data to support starting them. One question I had was, how far, like for example, bisphosphonates do come with risk of osteonecrosis of the jaw and things like that. So do people with like history of dental problems or like dental workup, do you need like some sort of dental workup before starting those if you know that they have dental problems? Do you order like a mouth x-ray or something like that? Or what kind of prompts you to look further, or do you not need to look further, or it's just anything that increases the risk of developing that we should look into?
Yeah. Great question. I would say that if you already know that a patient has some underlying dental condition, then maybe stay away from bisphosphonates. I did ask one of the rheumatologists that I'm working with, and he said that you give the bisphosphonates at least 5 months before they go for any dental procedure, which is going to involve like gingival manipulation. And then you can give it even, I think it was 1 month after they got bisphosphonate. So 5 months before and 1 month afterwards. You can give it, it's safe.
Yeah, my 2 cents worth, I think we can eliminate all these medications or whatever not if you simply, the degree of mobility that some of these patients have and having them lift weights and dietary more than anything else, especially eliminating Mountain Dew, Coca-Cola, and some of those sodas that destroy the bone structures like you wouldn't believe, at this point in time. Also, basic electrolytes like zinc, copper, and boron to be added to their diet. And another thing that is missed in all of these that I didn't see evaluation of testosterone. Always it's estrogen. No, you need testosterone also, as an accomplice. And the other thing, more than anything else, is vitamin K2, MK7, which is very, very important for taking out the calcium out of the arteries and putting them back in your teeth and your bones more than anything else at this point in time. So those are basically, the things that you would help more than any. Oh, and by the way, the majority of physicians do not give enough vitamin D. That's why the patients are very low. It should be at least 20,000 units every day, international units of vitamin D. And we're giving them like 600 or something like that, which is pitiful. It's almost nothing at this point in time.
Okay, thank you, Dr. Kode.